Adam Gaffney is an assistant professor of medicine at Harvard, and he practices pulmonary and critical care medicine at Cambridge Health Alliance. His research focuses on health equity, disparities in care for patients with pulmonary and pulmonary disease, as well as health reform. He also writes regularly for a general audience on health policy. And he's written a book called To Heal Humankind, The Right to Health Throughout History, published by Routledge 4 years ago. He's the immediate past president of Physicians for National Health Program. Adam went to medical school at NYU and has a master's in public health from Harvard School of Public Health. Did his residency at Columbia, where he served as chief resident, and then a fellowship in pulmonary and critical care medicine at Mass General Brigham and Beth Israel Deaconess. And it's with tremendous pleasure that I welcome Adam Gaffney to join us today to talk about how to pay hospitals and other issues of provider payment compensation. Thank you, Adam.
Thank you so much, Marvin, for that introduction, and it's good to be back. And thanks everyone for being here and having me talk to you about an issue that I find very interesting. Admittedly, I think it falls a little bit on the wonky end of the sort of spectrum of single payer issues, because I do think that a lot of what we care about most immediately relates to issues around healthcare access for our patients, right? Because ultimately we want people to get the healthcare they need so they can live as healthy lives as possible. And the things that I think often make us the most furious are those revolving around uninsurance and copays and deductibles and denials of care and narrow networks, and all the things that invariably hurt our patients, right? And that's, I think, what certainly pulled me into Physicians for National Health Program and health policy more generally, and I'm sure that that's true for many other people here. But the case I want to make today is that, for better or for worse, the nuts and bolts of the way that we pay for healthcare, okay, winds up being critically important in terms of the kind of healthcare system we have. The cost barriers and the lack of universal health coverage are critical, obviously. And again, perhaps the issue that I want to see fixed the most quickly and the most rapidly. But the case I want to make today is that in order to have a functioning, economically feasible and sustainable healthcare system, but also one that is equitable, you need to think about the supply side of the equation as well. And when you think about, economists refer to sort of the demand for care in a weird way. It's very determined by how much people can afford to pay for it, right? So that by doing things like getting rid of copays and deductibles and getting rid of uninsurance and covering everyone, you're basically, from a sort of traditional economics perspective, you're sort of focusing on the demand side, right, of the fact that there's inequities in the demand for healthcare, not stemming from people's not needing it or not wanting healthcare, but not being able to afford it, right? So I refer to those as inequities in demand, and it's a weird way to use the word demand again, because it's the economist's framing where your ability to afford something affects your demand for it, but it's worth thinking of in that way, but there are the supply side problems. And the supply side problems are both important. I want to argue, and I have a bunch of slides, but I just want to open up with a couple of preliminary thoughts. The supply issues are important, I would say, in three respects, a couple of which I've already touched on. One is simply the economic sustainability, okay? If, in fact, you were to cover everyone, and you were to eliminate cost barriers, but do absolutely nothing about the affordability of care. Let's say you gave all of the money to the private insurance companies and say, okay, fine, you cover everyone and you get rid of copays. That would ultimately not be economically sustainable, okay? And that's why the supply questions matter. The supply questions matter in two other ways, though, and we'll talk about this with hospitals in particular. They matter from the perspective of equity. We have a system in the United States right now where the distribution and type of healthcare infrastructure that we have is not determined just by the needs of communities. It's determined by the wealth of communities often, and often that translates into the racial composition of communities, so that we have poorer communities and communities that are more disproportionately people of color. And those communities, because of this way we pay on the supply side for healthcare, those communities have less healthcare facilities available to them. That exacerbates the broader inequalities of our healthcare system. The third way that the supply side matters, which I'm not going to touch about it as much, but is also important, putting aside the economics and putting aside the inequity, is how it relates to us as healthcare providers, how the way we pay for healthcare impacts our daily work and our daily lives, taking care of patients. And obviously that's connected with patient care. It's not just about our job satisfaction, but it's important. And because it relates to questions about the kind of healthcare system we want, both for patients and providers. So with that sort of broad overview, I hope I haven't put you to sleep yet. I'm going to jump into some slides, of course. And as is sometimes the PNHP tradition, I have a bunch, and some of them I won't be spending a lot of time on. But I also would encourage you absolutely to feel free to, what is this doing? To interrupt, raise your hand, or just jump in, okay? If anything's unclear, because if you wait to the end, you may forget it, and I may forget it as well. So let me talk a little bit, and again, this might feel a little in the weeds, with a very simple question, which is, how do we pay hospitals? And how have we paid hospitals throughout history? So I'm going to start with the revenue accounts of a hospital, and I don't really, I'm going to mispronounce it, but I guess the Hotel Dieu of Bavaria. And this is a medieval hospital. This is 1450, okay? And this is the revenue that this hospital received. And if you look at it, so what do you see? Well, you see, okay, they're getting cash. So this is cash payments, mostly rent, okay? Some donations. Here we have sales of patients' property, and I want to go back to that in a second. But this is sort of grim. This is after the patients died, they sold off their bedding and clothing. And you can see they get a very small amount of revenue from that. And then you see the biggest single thing is selling wine, right? So the hospital is staying in business by selling booze. 297, versus whatever. So the point that you might say, well, what does this have any relevance to today? And the point I want to make here is that what's remarkable about this compared to how we pay hospitals today is that almost zero of the total hospital revenue here is coming from individual patient payments, right? Now, I'm not using this as a model. I don't want hospitals to get back into, wine sales or selling off patients' possessions because they're so impoverished by the time they show up there. But the point I want to make is that having per patient billing of patients, the way we have it today, is not the way hospitals have always been paid. It's not the only way to pay hospitals. And there's actually a lot of inefficiency and injustice in it. It's actually relatively new in the history of society, the history of the hospital. All right. So again, feel free to jump in at any point. So then the question is, okay, well, we don't pay hospitals hospitals don't get their revenue anymore from selling wine or selling off possessions of patients. How do they make money, or how do they get their revenue? Although as cruel as the sales of patients' properties thing sounds, it is worth noting that hospitals do go after patients' possessions when they have unpaid bills. So there was a report, I think in either Kaiser Health News or ProPublica, about how Johns Hopkins was suing its former patients who had unpaid bills and put liens on their homes and pushed them into poverty and bankruptcy and ruin. So as cruel as this 1450 hospital practices might sound, we're not always doing so much better in the 21st century. All right, so here is a sort of simple way to think of the main ways to pay hospitals. And number 4, I've sort of put in parentheses because it doesn't really pertain in a significant way anymore. Okay, so the first one is called itemized charges. So what is itemized charges as a mode of hospital payment? Well, itemized charges is, basically everything that you get while you're in the hospital is tabulated on a bill, and then the long bill is made up, and the bill is given to the patient. Okay, or uncommonly nowadays to the insurer for this type of bill. So you've heard probably some horror stories about this. So how these itemized charges can get insane. Like this is a recent story about a guy who had a car crash, and you probably can't see it from there, but on the left side of the screen is a sort of tabulated bill, and it's $1,500 for bone marrow aspiration, and an injection of propofol is $108, and so on and so forth. So every little item is added up, tabulated into a bill, and those bills can be very high. The charge for each item is effectively just set by the hospital. Nowadays, the sort of list of all those prices is something called a charge master. And the reality is that there's been a lot of attention on these kinds of bills, but they actually constitute a minority of sort of the main determinant of how hospitals get paid today. But they do still matter for uninsured patients. So if you are uninsured, or maybe out of network or something like that, then and your insurer is not there to there's no insurer there to bargain a sort of lump sum, which I'm going to get into in a second, then in fact you may very well be hit by itemized charges using a charge master. And these bills can be extraordinarily high and often have little relationship with what a hospital would get paid if you had Medicare or any insurance for that matter. All right, any questions about that? All right, so then what's the next type of way hospitals are paid? So let me go back. There we go. So the second way that I want to mention is something called a daily charge. Okay, and it turns out, in many ways, this is sort of one of the oldest ways that hospitals got paid. And the daily charge is basically a simple concept. It's a sort of per day rate. For each day you're in the hospital, there's a certain amount that the hospital charges in revenue. Now, in Europe, from the 19th century, insurance-like funds would cover this. So, and famously, Germany, which is often said to have the first universal healthcare system, although that's sort of arguable depending on how you define it. The workers would have sort of a sickness fund insurance, and hospitals would basically take their total budget for the year. So let's just say, it's like $1 million. I'm just making up a tiny number. And then they would take the total number of patient days, like the total number of nights that a patient stayed in the hospital. And let's just say that was 1,000, just for argument's sake. That would mean that it would be $1,000 per patient day, right? So then when a patient comes the next year and stays for one day, then the charge to the insurance fund will be $1,000. And that is a sort of type of system that's existed throughout the world in many different countries, and it's a different name for the daily charge or the per diem in all these different countries. And the per diem was how in the United States, hospitals were, for the most part, paid by major insurers, specifically Blue Cross, okay, which is the first big hospital insurance plan. And actually Medicare followed Blue Cross, and it basically paid hospitals by this daily charge. But as I'm going to get into, the sort of collective logic sort of in the 1970s into the 1980s was that this was a terrible way to pay hospitals. And there was something right about that criticism, and there was something wrong, okay? So this is, for instance, a quote from the executive director of the Federation of American Hospitals, who's actually which is the for-profit lobbying group. That's right, the lobbying group for for-profit hospitals. Okay, and he says, it was a stupid. You don't give people that cost because you just give them an incentive to spend more. So the idea here is that the per diem rate is set by the total hospital costs. So that little math I did, 1 million divided by 1,000, you could tell that if the 1 million went up and became 2 million, then hospitals are going to get paid more. So as the costs, so it's not just that it's a per daily rate of paying, a way of paying hospitals. It's also that it's cost based. It's basically based on the actual cost of the hospital. But what this got wrong about the per diem was two things. This criticism. One was that, well, actually, a lot of European hospitals with universal healthcare systems use this approach at that time, and they were controlling their costs pretty good. So clearly, it wasn't sort of impossible. But the second point was that the way that this was being done in the U.S. was very different than it was being done in Europe, because in the U.S. These costs could include profits, and they could include investments, and they could include what we call capital costs, which I'm going to get into in a bit, which is the way the hospitals, when they expand or buy new facilities, those costs, they would all get bundled into into that per diem, so that it did create in the United States this tremendous drive towards a more profit-oriented healthcare system, because expansion led to more higher per diems, and then more per diems could allow you to plow more money into expansion and ultimately into profits. And so the U.S. moved away from this per diem model at a time that other European countries were not, on the basis that it was the problem of it was part of the reason why our healthcare system was so expensive. So in the 1980s, Ronald Reagan passed, and this is the third way that hospitals are paid, which we call diagnosis-related groups. In the 1980s, under Ronald Reagan, Medicare switched to a radical new way to pay hospitals, which is today the predominant way we pay hospitals. Okay, so what is this? This is something called the diagnosis-related group. And this, again, is the major way that both Medicare and private insurers pay hospitals today. It's the source of most of hospitals' income, putting aside those tabulated per patient bills that go to uninsured patients. So what is the concept here? So the diagnosis-related group was sort of invented or developed in 1970s at Yale University. And basically, researchers there were trying to sort of figure out sort of what the cost, sort of generic cost was for a hospitalization. And they wanted to basically define a price for a hospitalization, right? And to do that, you need to know what kind of hospitalization you're talking about. And so the researchers sort of talked with people in the management, and the idea here was that, like, you needed, and this is one of the researchers said, you need a product definition in a hospital. What is the product of a hospital? And so they defined groups of hospitalizations based on the underlying diagnosis and came up with a system that then paid a sort of set, predetermined, prospective lump sum for the whole hospital, right? So, for instance, a diagnosis-related group might be something like sepsis with respiratory failure, right? Pneumonia, a knee replacement. It's sort of the main thing that gets you to the hospital. And the idea here, conceptually, was, okay, well, rather than paying hospital that it costs under per diem, which sort of incentivizes costs to rise, while you want to control costs, if you could just bundle it into your payment at the end of the year, for the next year, let's come up with a price for each hospital episode, and that's what the diagnosis-related group was. Hospitals got a lump sum. Anybody want to jump in and say anything about how you could envision the incentives for hospitals to change in sort of the per diem cost basis reimbursement versus the sort of lump sum? Like, how might it affect patients? How might it affect hospitals' sort of financial incentives in terms of things like lengths of stay or other things? Anybody have any thoughts?
I think in part it could incentivize efficiency because you're getting a lump sum ahead of time. So yeah, for like length of stay, previously you would get more the longer that they would be there, but under this you wouldn't.
Mm-hmm. Absolutely, and that affects. I think we'll we'll put it aside the efficiency for a second because that's complicated, but you're right about the length of stay, right? So before this diagnosis-related groups introduced in 83, I believe, with maybe 82, the length of stay were longer. All of a sudden, hospitals were like, we got to get patients out of here quicker because we're losing money every day longer they stay that, they don't really need to. Okay, now you might say, well, it's not good for people to be kept in the hospital for like a week for, whatever, an uncomplicated appendix removal. Sure, but there were some unintended consequences. Any thoughts on what a sort of potential unintended consequence might be?
Upcoding. Now you're in
Excellent.
the hospital instead of for hypertension, it's accelerated hypertension.
Excellent. So, and that I'm so I just like who said that? Because you just give me your name so I know. Can I?
Sheena.
Sheena, thank you, Sheena. So that is a very excellent point, right? So in this case, the price for each of these, it can't just be something totally generic like hypertension, as you said, because that could imply everything from someone who doesn't even need to be in the hospital to someone with a hypertensive emergency who has cerebral edema and all the sorts of things that like I see in the ICU. So you need to have different levels. But the problem is the hospital itself is the one that's determining the specific codes that determine the levels. So Sheena is absolutely right. What happened after this, and this remains a problem to the present day, is hospitals upcode often, making patients look sicker and sicker because that actually is what determines the price. Okay, so that's a really good example. Anything else? Well, going back to the length of stay for a second, as I said, you don't want patients to stay in the hospital longer than they need to, right? Obviously. However, you could also envision that patients are being moved out of hospitals earlier than they're ready, right? And that's certainly been a concern here. And what happened after the DRG system was created was that nursing homes really rose, discharges to nursing homes. Basically, patients who are still sort of sick and not really ready to go home, well, rather than keep them in the hospital 5 more days, you have them go to a nursing home for sort of subacute rehab. And so discharges to nursing homes soared. And maybe there are times when that's appropriate. Maybe there's times when that's disruptive and a patient would be better off just spending 4 more days in a hospital, right? Rather than having one more change in place. And you can argue about that for individual patients, but it's not a totally clear-cut efficiency necessarily if it means that there's still costs elsewhere. In fact, you can't do this with ICU patients, but around the same time, in order to the fact that hospitals, when they had patients on the ventilator for a very long time, well, that's losing money too. So there are new type of hospital emerged called the long-term acute care hospital, sort of a contradiction in terms, and those hospitals basically accepted, long-term mechanically ventilated patients, and the huge increase and in those hospitals, and that industry wound up being taken over by for-profit companies almost entirely, and has been sort of criticized in many ways, both in terms of the amount of care those patients are getting, and sometimes even whether that level of highly invasive care for patients who can't get better is always appropriate, or if it's being fully addressed with patients and their families, the kind of care that patients are receiving. So anyway, these sorts of things have consequences. And despite all of the hopes that this system would rein in healthcare spending, it actually turns out that after the 1980s, US healthcare spending accelerated. I didn't put this graph on, but I should have. But if you look at healthcare spending, as a proportion of GDP in the US versus other high-income nations, we're used to the US being the most expensive country in terms of healthcare. We all know that. We all say it. But the reality is, in the 1970s, the US was a little more, but it was sort of in the pack, okay, with other countries in Europe. It's really from the 1980s onward that the US sort of takes off on its own in terms of healthcare spending. So clearly, you could say it would have been even higher had this system not been implemented. I'm skeptical of that. But clearly, overall, it didn't work to fix the problem of high American healthcare spending. And it did create some new problems like upcoding and like, discharges to other facilities that maybe in every case are not always optimal. All right, so I want to then turn to the final mode of healthcare, of hospital financing. And again, I hope I haven't lost you. We've only covered 4 so far. The per patient, charges, the per diems or daily charge, the DRG system, and the goal budgets. So goal budgets we talk about a lot in Physicians for National Health program, because this is the model that is in our proposal. Now, many countries use goal budgets. Canada, in the US, Veterans Affairs hospitals, Scotland does, and other countries historically have, but some have actually moved to DRGs sort of in response to American healthcare economists, authority, I would say, perhaps misguided in my opinion. So the goal budget is the easiest to sort of understand. It's actually very close to the per diem. Remember when I said a per diem is like, okay, your budget's $1 million, you have 1,000 patient days, so the per diem is $1,000. The goal budget is just $1 million, right? So rather than getting that per patient per bill, per diem, you just get the full $1 million with the expectation that last year's amount is going to basically amount of care you provide is going to be similar next year. And goal budgets can be adjusted if there's going to be expected changes or new services provided, that sort of thing. But the goal budget is similar to the per diem in the way I just described, but it's even simpler. It's a single total lump sum that you use to cover all of your expenses throughout the year, and there's no per patient billing, right? So you're not even tabulating the bill at all for each individual patient. And US hospitals do tabulate the bill for each individual patient, even when they get paid by a DRG, by the way, because that's just how the infrastructure has to be, because sometimes they do need to charge the patient, or don't need to, but choose to. So goal budgets are very simple. Now, you might say, well, okay, well, is there anything else like that? Well, there is. So this is basically how schools get paid, right? So if you're a primary student, a 5th grader, you don't like pay on your own to be there, a daily charge, or if you had a sort of tabulated bill system, and the analogy in public schools would be if like you show up and like the kid gets billed for the amount of every time the teacher talks to them, and like every bit of chalk they use, and like the amount of time they spend in this class and that class, and create a huge bill. That would be totally insane and would not help anyone. It would be a massive waste. And so schools basically get a lump sum for their total budget for the year to pay for the teachers and this supplies and heating and so on and so forth, and they cover everything. That way they don't need to do per student billing of any sort. Fire departments are also paid this way. So other sorts of services are paid for the goal budgets. Even if you think of a public park, right? You don't pay a fee when you go to a public park. You don't actually try to compute a per individual visitor sort of amount of money. Parks just get a certain amount of money to cover all their expenses. And so that's the goal budget. And you can see that there may be upsides, there may be downsides. Anybody want to point out what you see as, maybe apart from maybe what I've said, any ways you see this could be useful, or even could this be problematic?
Well, I guess one issue that might come up is similar issues that came up in the per diem system, where if we don't have regulations on what hospitals can spend their money on, they can also spend their money on profits, investments, and capital costs.
Yep. And so we're going to get into that. And that, I think, is a critical issue, that, if this system were to simply allow hospitals to spend as much as they want, including on capital, well then, okay, I'm a hospital, I can just build a second hospital next to me, and suddenly my goal budget doubles, and and then I'm also going to take some of that as profit. Like, well, that's great. So I think it's a really good point. There's simplicity, but it also requires you to go beyond. And specifically, I think capital. None of these systems can these hospitals take profits, right? The Veterans Affairs can't take a profits. The Canadian hospitals, there's no profits. In fact, they basically use the money they get, and whatever, if there's anything left over, they can't take it home. But you're very right in thinking about the capital expansion issue. If you're going to do something like this, it can't simply be that a hospital can say, I'm going to just open up a giant new facility that may not be needed and suddenly expect that the global budget's going to double, right? Because that's unsustainable economically. Excellent. How about in terms of incentives of upcoding? Does that factor in?
I suppose if they had access to supplemental funding that they could request, then they have an incentive.
Yeah, I mean, I guess if you have the sort of existence of other types of insurance within this, then that could persist. But you're right, and in which case it wouldn't really be a global budget; it would be a sort of sub-global budget. But you're right. If you could have that incentive if there were other mechanisms, but overall, you really don't have. It does help with that incentive. That you don't have the incentive to sort of make patients look sicker than possible. Some people would say, well, is it going to sort of not incentivize hospitals to provide more care? And that's, there's always this downsides of every way you pay. But overall, probably one of the biggest benefits of this approach is that one, the simplicity. We're going to talk about that. You don't actually have to compute bills. That in of itself is an enormous efficiency. The second, though, is that if you do it right, if you don't allow the global budget to be used for, and I forget who said that. I keep meaning to ask you that. If you don't mind, just say your name when you speak this, so I can remember his name. If you don't have sort of, it also requires you to have restrictions on profit and on capital. But if you do, then you could transform hospitals' sort of overall approaches, overall strategies away from a profit-oriented perspective. And that's going to be a big advantage. All right, so let's go on. Let's talk a little more about hospital payments and about sort of trends and what's happening with hospital ownership recently. So you already heard a little bit. I touched briefly on a couple other providers and hospitals. But I want to focus on hospitals. I know you've already had a discussion on primary care, physician payment earlier. But one of the points I want to make, the second point I want to make, apart from giving you a long-winded history of how hospitals are paid, is that one of the problems in the US when it comes to the supply side isn't so much that the supply of healthcare in America is too little or too much. In some cases, it may be, but often it's about the distribution, both geographically and in the kinds of supply, right? So just to give an example, this is just a graph showing sort of the supply of primary care doctors and specialists in the United States from over the last 15 years or so. So you can see that the number of specialists that we have per capita has actually gone up. The number of primary care providers has actually gone down. And some evidence suggests, and not surprisingly, that sort of the effect of having doctor supply on life expectancy, that primary care overall is delivering more goods in terms of more life years than specialists. And I feel comfortable saying this as a specialist because it's absolutely true. What we do in, say, the ICU, I think is important. I wouldn't do it otherwise, but it's affecting a relatively small number of people and probably changing outcomes, not in a very small proportion of the overall population. Whereas things that happen in primary care, like something as simple as high blood pressure control, which prevents strokes, heart attacks, death, renal failure, that's having a much broader population level impact. So anyway, that's sort of not surprising. But so that's a good example of where people talk a lot about physician supply, but this sort of mix is perhaps the more salient issue. How are hospitals and ownership? So there's been a real change over time. This is, in terms of the kinds of hospitals we have. And one thing that is notable, this is actually showing a proportion of hospitals owned by nonprofits, for-profits, and public the government. And you can see some sort of interesting trends over the very long term of American history. For one thing, you can see that there used to be actually a lot of and this is a little misleading of a graph because of the reasons I'm about to explain. You might say, wow, like back in the 20s, there was like for-profit hospitals were a much bigger thing than they are today. And what's that about? Like I thought we're a more corporatized society today. And the reality is that these for-profit hospitals way back in the day, 100 years ago, were these tiny little things that were sort of set up by like you and two doctors would get together and be like, let's open up a hospital, and it would have like 4 beds and it would be a for-profit. And that's a lot of what was happening back then, right? However, for the most part, nonprofits have retained dominance over the market share in the United States. But there's two important things I want to point out. One is that right beginning in 1980, you can see that the for-profit share begins to rise again after sort of hitting a nadir in the 1970s. So as part of, with the change in the DRGs, with other changes in the US healthcare system, at the same time as our overall healthcare spending, as I mentioned earlier, starts to rise sharply relative to other countries, we also see a sort of rising for-profit market share of hospitals. At the same time, you see a fall in public. So public-owned hospitals is beginning to decline, county and state, mostly county and local hospitals. And so what's important about this is that these for-profits in the 1980s are very different than the for-profits in the 1920s. In the 1980s, what we're seeing is the growth of giant for-profit, corporate, multi-hospital, multi-state, transnational chains like Tenet Healthcare or Hospital Corporation of America. So this is the heyday of sort of corporate big hospitals. And so they are growing. At the same time, the nonprofit hospitals are sort of still hanging in there. And if anything, it's still expanding. But they are developing increasingly some strategies and some approaches towards billing and towards expansion that increasingly resembles that of corporate America. I'm not saying it's the same, but increasingly resembles. Now, just as is the case with physicians, an important part of, and I'm going to get back to the ownership bit in a little bit, just as is the case with physicians, the problem, some of the problems with supply is less about do we have too little or too much overall in aggregate, but what type, the mix, but also the distribution, which is what I want to focus on more. But just again, to give you a sense of like the mix here, we've actually been having declining numbers of hospital beds in the United States over the last 15 years, right? Is that a good thing? I'm not so sure it is. At the same time, we're having growth in ICU beds, the most intensive, the most invasive types of care. And obviously, again, I'm an ICU doctor. I think a lot of this is appropriate and helpful, but we also do a lot of procedures in this country and a lot of excess of utilization that is often not beneficial to patients, sort of so-called no value or low value care. And so we're seeing a sort of divide towards more, more specialists and more intensive levels of care and sort of away from primary care. So, when we went into the COVID-19 pandemic, you had this sort of funny situation where we sort of had the most ICU beds per capita of any European country, but less overall hospital beds than most. All right, but I want to talk now. So we've talked a little bit about the 4 or 5 modes of hospital payment. And so just a quick time check. We started 10. We're ending at what time again, Marvin?
Around noon.
Around noon. Okay, so we still have a half hour. Great.
We'll give you a few extra minutes if you need them. You're doing a good job, Anna.
Okay, thank you. I'm trying to keep this as sprightly as possible. But one of the key points I want to make here. So we've talked about the history and the modes of hospital payment, and I've sort of touched on a little bit the issue of overall supply and ownership of hospitals. But I want to talk about inequity, because I started off the talk about this, saying that we speak a lot about expanding insurance coverage as necessary for disparities. But there's also supply side disparities that are affected by our for-profit sort of mode of financing. When you pay on a DRG basis, right? And if some DRGs are more lucrative than others, and if some patients have insurance that pays higher DRGs, like private insurance relative to Medicaid, right? Then you're going to create a system where the doctors and the pharmacies and the nursing homes and the hospitals that serve well-off patients are going to be able to make more money, and they're going to be able to potentially provide better care as a result. And that's not a surprise, right? We know that oftentimes hospitals in well-off areas have resources that hospitals treating poor people do not. Not a surprise. But I want to show some of the data showing of how this is evolving. Here's just a very simple example of this. In Philadelphia, neighborhoods, as the neighborhood, the proportion of a neighborhood that is African-American goes up, less than 20% to 80%. The proportion of neighborhoods that have low access to primary care goes up, right? So 6% of neighborhoods that have less than 20% African-Americans are low access primary care areas, whereas neighborhoods that are predominantly African-American are 31% primary care low access areas. And you see a similar trend as the proportion of a neighborhood that is uninsured goes up, right? So it's not just that uninsured people can't afford care, it's that uninsured people, and in this study, African-American patients are also live in areas that don't have the care they need. So this is a little different than what we used to talking about, right? We used to talking about inability to afford care. This is related. It's the same financing problem that gives rise to these geographic inequalities, but they exacerbate and they sort of work together with the demand side inequalities. Here's another example. Looking at race. This is again the racial predominance of a neighborhood, and what is the likelihood that it loses either an ambulatory care facility or a pharmacy over the period of 2000 to 2014. So you can see that Black predominant neighborhoods had an odds ratio of 2.37, which basically means 137% more likely to lose one of those facilities over this period relative to white predominant neighborhoods, right? So healthcare infrastructure is moving away from predominantly Black and Hispanic neighborhoods. And that's because of the way we finance these facilities, not on the basis of need, but on the basis of profitability. Now, what happens now, we've heard a lot about rural hospital closures, same basic idea, right? We don't pay rural hospitals with a goal budget that stays the same regardless of what kind of patients they have, or if the patients are uninsured, or even if their patients, they can't get enough patients because it's sparsely populated areas, right? We pay them with those DRGs that we are talking about, price per patient. So if they're unable to really do well with that, or they're worse at upcoding, or they're worse at coding in general, or they just have a drop in DRGs one year, well, they can close, right? And that won't happen with a globally budgeted hospital because the budget stays the same. So we have obviously this big problem of rural hospital closures. Okay, everyone knows that. But what's important to note is that there are downstream consequences of this beyond losing a hospital. When the hospital closes, in this study, there's a 9.2% reduction in the number of physicians in the area. There's an 8.3% reduction in the number of care doctors. There's a 4.8% reduction in the OBGYNs. And this is not rocket science. There's no hospital that can be hard to practice medicine, but it just goes to show why these rural hospital closures matter. But again, hospitals are what I wanted to talk about. And so I'm going to show more evidence of this sort of spatial, racial, economic inequalities in the supply of healthcare that result from the approach we take to financing hospitals. If you look at cities like Chicago or Los Angeles, for some reason it's didn't pan out in New York, but there are other inequalities there. If you look at Chicago or Los Angeles, this is a study looking at the proportion of neighborhoods that have no trauma care, no advanced trauma care facilities within 8 kilometers, based on whether it's a white majority neighborhood or a Black majority neighborhood. So you can see like in Chicago, and there was a big actually move to get a new trauma center in Chicago that actually ultimately was successful, a grassroots movement. But you can see that Black majority neighborhoods in Chicago in 2015, 73% were trauma deserts, meaning an area with no trauma center nearby, right? And that makes no sense, obviously, versus only 24% of white majority neighborhoods. So these are the kinds of supply inequalities that stem from our broken mode of hospital financing. Another way of looking at the same exact thing. This is a study looking at, but what's important with this study is showing that it's not just, oh, this is the way it's always been. This is showing, oh, it's actually getting worse. This looks at the 2001 to 2007 period, and it's asking what is the likelihood of the drive time to the nearest trauma center increasing by 30 minutes or more, okay? Meaning for each community, each zip code in this case, what is the likelihood for a given zip code, seeing a 30% increase driving time to the nearest trauma center? And 30% driving time to a trauma center is a huge amount, right? Obviously, if you get shot, a 30-minute drive time to a hospital is potentially going to be incongruent with survival, depending on what the injury is, right? So this is very, very important. And again, you can see, not surprising, there's no correlation with need for trauma care. In fact, there's an inverse correlation with need. As the share of population in poverty increases, the likelihood of having that increase in drive time increases by 32%, right? So 1.32 is basically 32% higher risk of that happening. Share of African-American population, same rate, same relationship. And share of uninsured population, an even bigger relationship. And again, this is not because uninsured people are not trauma victims. It's because of the financing. And feel free to jump in. Is there any of these slides or relationships not make sense? All right. So I'm going to
Adam, it doesn't make sense at all that we have a country that's not serving its population. Yeah, that doesn't make sense.
It's awful, right? And I'm going to get to what one physician once called this inverse care law, but we have a financing system that is actually not only underserving people with the greatest need, it's actually increasingly pushing resources away from the communities most in need. We saw this, I'm going to skip this. We saw this with COVID-19 too, where, well, it seems like, the places where you had the most ICU beds weren't necessarily the place where people were getting the worst COVID, right? Or getting the most of the worst. So we already knew there was a lot of geographic sort of inequity in ICU distribution. But I want to bring up this one study. So again, this is a very simple study. It looks at the proportion of a community that has 0 ICU beds in the whole community based on whether it's a rich or a poor community. So the first bar is the proportion of poor communities, defined as median household income less than $35,000, the proportion of the poor communities that have no ICU beds. And about half of poor communities have no ICU beds. If you look at richer communities, almost 0% have no ICU beds. Again, the same relationship. But it's not just about is there or not. It's about, do the hospitals have equitable amounts of infrastructure and funding for each patient they see? And you will be unsurprised, the answer is no. This was a study by came out just last year, and it looked at a very simple question. How much total capital assets, and by capital assets, we're defining that as physical infrastructure, the beds, the CT scans, the building, the plant, the grounds, the PET scanners, the MRIs, the surgical suites, the cardiac labs. How much total physical infrastructure do hospitals have per patient, depending upon whether they are predominantly Black serving or predominantly Hispanic serving or predominantly white serving? And you can see that hospitals that are predominantly Black serving have about $5,000 in physical equipment per patient day, whereas other hospitals have a lot more, 8,000, right? And so it goes to show that Black serving and Hispanic serving hospitals basically have less physical resources to take care of their patients. Sometimes that may, sometimes perhaps that difference is things that are that are waste, or not that helpful, like a pretty atrium. But some of this is clearly essential too, and so it shouldn't be surprising that outcomes in some cases may be worse for hospitals that take care of poorer communities. And then finally, we've seen something very similar with who's losing nursing homes. So nursing homes have been closing to some extent over the last 20 years, not totally, but there has been a fall for a variety of reasons. But again, the distribution is not equal. In Black, Hispanic, and poor neighborhoods, zip codes, they lost a lot more nursing home beds, whereas the richest neighborhoods actually gained nursing home beds. Again, nursing homes aren't the answer for everything, and I think we want to be doing a lot more long-term care outside of nursing homes. Almost everyone agrees, but the reality is that where things stand now, this is often a needed healthcare infrastructure, and it's being shed in poor places, and it's being not shed in richer places. And you can see this in the headlines too. This was in 2019. I wrote an article about this. It was in the news. A big sort of safety net hospital in downtown Philadelphia that served, a poor, disproportionately person of color Medicaid population, closed. It was bought up by a private equity company, and then basically sold for parts. And at the same time, Mass General Hospital, up by me, announced a $1 billion expansion project. So this is happening in the news every day. I want to talk briefly about the Hahnemann, not so much its case specifically, although there was an article on it in the New Yorker just recently, which I actually haven't read yet, but I hear is very good. So if you want to learn more about private equity and Hahnemann, I recommend that. But this problem of private equity entering into the healthcare space is increasing in the hospital sphere. So private equity companies are not just for-profit corporations, right? Which we talked about how in the hospital sphere, they kind of began to rise in the 1980s. Private equity, basically uses funds to buy out healthcare, often load it with debt, and then often sell it and sort of turn a profit on it. And so it's a way of basically squeezing, these firms and sort of bringing them for as much as value as possible, and then often offloading them in worse state. Or in the case of Hahnemann, it just got sold off, and who knows, maybe turned into condos or something. So this is becoming an increasing problem. Here's a recent study just showing how PE firms, acquired 282 hospitals from 2003 to 2017. Hospices are increasingly being taken over by private equity. 12% of Medicare patients in hospice were in private equity or publicly traded corporation-owned hospitals, meaning like you could buy stock in the hospice, and that's up to 16% in 2019. This was in the news too, because private equity groups have bought up doctors' staffing firms. And during COVID, they were sort of slashing benefits for the doctors, even as they were sort of fighting COVID on the front lines, taking away their time off and whatnot. But one of the ways that they make money is by cutting costs. And one of the ways you cut costs in medicine is by firing staff and reducing the amount of staffing. So this study, for instance, found that private equity-owned hospitals have on average 12.6 mean full-time employees per occupied hospital bed, which is significantly less than 14.5 among other hospitals. And when you have less nurses taking care of patients, when the nursing rate to patient ratio goes up and up, at some point patients get harmed, right? And perhaps not surprisingly, this was a study that came out recently, and it's really gut-wrenching. These researchers looked at private equity acquisition of nursing homes, and they found that private equity ownership of nursing homes leads to, not just associated with, because they use sort of quasi-experimental methods, leads to a 10% increase in death, short-term death among nursing home patients, and actually an increase in costs. And one mechanism for this potentially is shedding nurses and shedding staff. And I do want to leave some time for questions. So I'm actually going to probably, Marvin, what do you think? 15 minutes for questions? Would that be good? Or
Adam, yeah, I think 15 minutes would be good. And Phil Verhoef is coming Monday to talk about the consolidation thing. So that, just to let you know.
Good. That's good. Well, I don't have too much on it, so I'll defer to Phil on that. I have 2 slides, and really just to point out that hospitals are becoming increasingly consolidated. I think you've all heard of that. Lone hospitals are becoming increasingly uncommon. I grew up on Long Island, and I read recently that there's only a single independent hospital left on Long Island. So hospitals increasingly are becoming part of large systems. Okay. It's a problem for a few reasons, and I'm only going to show one slide because it sounds like Phil's going to focus on this. When you have one problem with consolidation is it can lead to rising costs, and the reason's obvious, right? If you have a monopoly in an area and a private insurance company wants you to be part of its plan, so like if I'm the only hospital in Boston and Blue Cross, who has all these clients, wants their people in the Blue Cross plan to be able to go to my hospital, I can sort of name my price, right? So studies have found, and the effect isn't not as big as you might think, that areas that have a monopoly hospital are able to charge private insurers about 13% higher prices. So what I'm going to do, so this is all part of, I think, the same phenomenon. And maybe I'll sum it up, and I want to end with the next 2 minutes with just a couple slides about how things can be different under single payer. Actually, I'm going to go straight into that. So what is different under single payer? Well, several things. First off, and we got to this earlier, you can pay hospitals differently. By using that global budget model, you eliminate all of the costs of for-profit patient billing, tabulating all those incredibly complex bills. At the same time, you can do something called health planning, where you separate the capital and the operating expenditures. When you don't do that, you get what we have seen in all those slides. You get the inverse care law, which I alluded to earlier. The inverse care law is sort of this idea that's sort of, I guess, commonsensical to some extent, that was coined by a British general practitioner named Julian Tudor Hart, and in the Lancet in the 1970s. And Hart was a socialist. He was a sort of prominent epidemiologist, healthcare thinker. And Hart wrote, the availability of good medical care tends to vary inversely with the need of the population served, which is basically just what every graph I showed you, that as need went up, I didn't focus on need, but need often does go up in those poor communities. The amount of care actually paradoxically declines. When you can separately finance capital expenditures, you can directly push back on that law, because you can make explicit decisions about where you build new hospitals, where you build new CAT scans or MRIs or nursing homes or whatever, based on the communities that need them, not based on the community's profitability. So that's a critical part of hospital financing under single payer, the ability to start to fund based on need, not based on means. And that allows you to reverse the inverse care law. It's not going to happen overnight, but it can be done. And it's been done in countries that have done single payer. Controlling capital expenditure is also important, I think, for what someone brought up earlier, which is if you don't do that, you can't control costs, right? And I mentioned that already. If you don't control capital and hospitals can sort of still engage in a profit-oriented approach towards building new facilities, well, then suddenly you're stuck with the goal budget for those new facilities, and and there is no cost control. So you need it both for equity and justice and for sustainability economically. So because this is a hospital, I have a lot of slides here, which I'm not going to do, just about total economics of single payer and how it winds up shaking out to save money, not just according to proponents, but according to a recent analysis by the Congressional Budget Office. But I want to say just a quick word about hospital finances under single payer. Okay, so we know that we spend a huge amount of money in the United States on healthcare administration. Private insurers, we spend 34% of total healthcare dollars in the US on administration versus 17% in Canada. So it's a huge amount of money that we waste. And a lot of that is because private insurers have very high overhead and profit relative to traditional Medicare, which is closer to 2%. It's more like 12% among private insurers. But part of the issue too is that hospital administration in the US is extremely expensive. And this is where I'm going to end up and conclude. Because of the complicated way we pay hospitals in the United States, not only do we get inequity where we have hospitals, right? Not only do we necessarily not get the right type of facilities or intensity, we also waste an enormous amount of money. For hospitals to engage with innumerable different insurers, each of which has their own set of billing requirements, each of which has a pushback that they go back and forth. For hospitals to bill each individual patient, to chase them down, to sue them, to send them bills, to collect copays. All of this winds up generating an enormous amount of waste. About 1/4 of total hospital revenue in the United States is spent on hospital administration. The more simple you make the payment system, the more savings you have. So if you compare us to a pure global budgeted hospital system like Canada or Scotland, you see that they have less than half of hospital revenues going to administration relative to us. Countries that have started to move in a free market direction with more DRGs and that sort of thing, like I mentioned earlier, they're sort of starting to creep up towards us in terms of how much they spend in administration. But this is a very clear cost savings argument for simplified hospital expenditure system. But the point I wanted to make today is that it's not all about money. Yes, I think these savings help you achieve universal coverage, get rid of copays, get rid of deductibles, get rid of uninsurance. They help you do that without increasing health spending. But it's also about justice. It's also about achieving equality, both economic, racial, and ethnic. And so I think I'll just end there, and we can just sort of have a discussion about some of the many issues that this has raised. So thank you, and thank you for having me.